So just a few things before we begin. As there are quite a few of us on this call, could people make sure that their mics are on mute? And secondly, if people do have questions, can we put those into the chat? And my colleague Charlotte is monitoring the chat and will raise these questions at a suitable time. Lastly, this webinar will be recorded. So if anyone has any concerns with this, please make sure your camera is off. So these are the hosts and speakers today. My name is Mike. I'm one of the key account managers here at AGHealth, the UK distributor of Dilapan-S. There is also Charlotte, who I mentioned will be monitoring the chat. She's another one of our account managers. And we also have Louise, who is one of our product specialist midwives, who will be just running through some details on Dilapan towards the end of the webinar. And then obviously we have our experts. We have Professor Gupta, who is a professor of obstetrics and gynecology at the University of Birmingham and Birmingham Women's. And we have Dr. Zaher, who is a consultant obstetrician over at Cardiff. Just a quick run through of the program. Before we begin, I will just give a quick run through on Dilapan, just in case anyone on this call is unfamiliar with it. We will then have the SOLVE trial overview with Professor Gupta. After that, we'll have the inpatient economic analysis with Dr. Zaher. And then after they've finished their talks, we will give an example of a Dilapan IOL pathway. And lastly, we'll have a Q&A with our experts, as well as with our product specialist midwife, Louise. So what is Dilapan-S? It is a osmotic cervical dilator, which gives a predictable, non-pharmacological induction of labour with high maternal satisfaction. And it has 3 modes of action. So the first is biophysical. It works by absorbing fluid from the cervical tissue, causing a osmotic dehydration of the cervical tissue, therefore softening it and creating a change in consistency. Alongside that, we have the obvious mechanical pressure, where these expanding dilators exert pressure on the walls of the cervix and cause gradual dilatation of it. Then lastly, we have the physiological mode of action. This mechanical pressure on the cervical walls does stimulate the release of natural endogenous prostaglandins, which can then further efface the cervix. So that is Dilapan. Just to run through our speakers today, our first speaker, I've done a quick overview, but Professor Gupta, as I mentioned, is a professor of obstetrics and gynecology at the University of Birmingham and Birmingham Women's Hospital. He's been a consultant since 1995 and has published many peer-reviewed papers. He has had many great impacts on gynecology and obstetrics and is therefore playing an important part in the future of induction of labour. So he will be presenting the SOLVE trial, which is a randomized controlled trial comparing synthetic osmotic cervical dilators to vaginal dinoprostone.
Okay, thank you. So this is quite an important study that was carried out as an important adjunct to use of induction of labour methods, and the idea was set up a long time ago, but is culminated into the SOLVE trial and many other trials that have actually currently been published on the use of mechanical osmotic dilators, Dilapan-S, in the context of induction of labour. This was published this year in the American Journal of Obstetrics and Gynecology, FMN, and essentially it is a randomized controlled trial, next slide, of nulliparous women. So 80% of women that were recruited into this trial were nulliparous women in both groups, hence the randomization being effective. Next slide. The primary outcome measure that we wanted to look at was the failure to achieve vaginal delivery. So in other words, cesarean section. What is the rate of cesarean section delivery in women undergoing induction of labor using either Dilapan-S or dinoprostone, which is the PGE2 slow release prostaglandin, and it's non-statistically not different between the two groups. Next slide. It showed that the first round of cervical ripening effect, when you put the Dilapan-S in or the dinoprostone, was better in the Dilapan-S group. So when you put the rods into the cervix, and this takes some learning curve compared to dinoprostone, which is just putting a tape into the vagina, the effects, if you manage to get the cervical rod through to the internal os, like you do with a balloon, it's important to make sure that the tip of the rod goes through the internal os. Then the cervical ripening effect success rate is significantly better with the Dilapan-S group compared to dinoprostone in the first round of series. Next. So the reasons that we found that was for a failure to ripen or slow progress was reported as unsuccessful first rounds in lower number of Dilapan-S compared to the dinoprostone. Next slide. We also found that, interestingly, we know from personal experience that actually dinoprostone can fall out, and you have to reinsert these dinoprostones because it falls out. It doesn't, we didn't find Dilapan-S, and with other observational studies, Dilapan-S, when it's fitted properly, doesn't fall out, whereas it does with dinoprostone. Complications during cervical ripening were much lower in the Dilapan-S group compared to dinoprostone. Now, these are important complications that we were looking at. These were uterine tachysystole, which is known to be a problem with prostaglandins. Uterine tachysystole is defined as uterus contracting over 5 in 10 and is an issue that can lead to fetal heart rate abnormalities, and that effect is seen in hyperstimulation. So uterine hyperstimulation is when you've got uterine tachysystole with fetal heart rate abnormalities. And you can see that there was a difference with no evidence of uterine hyperstimulation in women with Dilapan-S versus the prostaglandin effect. And the effects on the CTG were significantly less with Dilapan-S, in less than 2.5% compared to dinoprostone, which was over 10%. So it shows that actually the use of osmotic mechanical dilators does not affect the uterus, nor does it have an impact on the fetus. Next slide. There were some adverse and serious adverse events, and these resulted in one case of neonatal death, 3 cases of HIE, one of which was the neonatal death, and 1 case of placental abruption. All of these occurred in the dinoprostone group, and none occurred in serious adverse effects in the Dilapan-S group. Next slide. Analgesia during the cervical ripening process was significantly less in the Dilapan-S group, and these were because less use of opiates and pethidine. But we noted that the initial, at the time of fitting of the Dilapan-S, more women did use Entonox whilst they were getting the Dilapan-S fitted. So that during the actual fitting process, Dilapan-S requires more analgesia, mainly with the use of Entonox. But subsequently, evidence from the trial shows that there's less use of analgesia overall and less use of opiate analgesia. Next slide. The time that we found, and this is unfortunately something that is a pragmatic issue that is inherent in most maternity units now in the UK. So when the cervix was found to be ripened to the point when you need to do amniotomy, there was a significant delay, and that was up to 30 hours in both groups. And this is something that we're having to deal with on a regular basis. This is not inherent in the study, but universally a UK maternity issue. Next slide. Amniotomy is undertaken more often with Dilapan compared to dinoprostone, so there will be more women who undergo spontaneous labor with dinoprostone. That is not an unexpected finding. This is something that is as a result of uterine activity that starts with the use of prostaglandins. So more women will need to undergo Dilapan related amniotomy. Next slide. And therefore, the use of oxytocin is higher in the Dilapan-S. So once you've done your amniotomy, more women, percentage-wise, will undergo the use of oxytocin compared to the dinoprostone. In a sense, this is actually a positive thing when we consider how we're going to potentially manage women undergoing induction of labor in maternity units now, which will be discussed later. Next slide. What is more important is that whilst the induction process is taking place, i.e., let's rephrase that, when the cervical ripening effect is taking place, more women had better satisfaction rates with Dilapan compared to those with dinoprostone. So these were essentially those, how much pain did you have? Were you able to perform your daily activities, i.e. walking, dressing, hygiene, able to relax? Did you have some sleep time? Were contractions frequent, intense, and overall pain? These were all significantly better with the Dilapan-S compared to dinoprostone. So the quality of life during that cervical ripening process was significantly better with Dilapan. Next slide. So the key take-home messages is that women undergoing Dilapan have similar vaginal delivery rates compared to dinoprostone. But the more important thing is that from a safety point of view, there are less instances of uterine tachysystole, hyperstimulation, and fetal heart rate abnormalities. More women with Dilapan reported better satisfaction rates. Next slide. Next bit. However, there is a need for reinsertion of dinoprostone by approximately 10%. You could then assume that the cost of Dilapan is 10% lower, or the cost of using dinoprostone is 10% more. The trial also showed that the Dilapan-S has lower safety or higher safety aspects and lower serious adverse events. The need for analgesia is specifically lower in Dilapan, especially the strong opiates. Next one. Number of dilators we used was usually 4. So 4 rods are usually put in, so between 4 and 5, inserted for up to 19 hours, giving you a progression from an unripe cervix to a ripe cervix by a gain of 3 points, over 3 points in Bishop scoring. And so it shows a predictability of using a very specific insertion and then getting a result of cervical ripening effects, usually 12 to 15 hours later. In our study, because we left it in up to 24 hours, that effect is possible, so within 24 hours. Okay, next slide. Because it doesn't have any issue with causing fetal heart rate abnormalities, we can use Dilapan in women who have growth-restricted babies, or those who have got reduced fetal movements, or at-risk babies. So Dilapan-S could be used in these high-risk groups, which takes us potentially to using it as an outpatient procedure. So you could fit in the Dilapan-S, get them to go home overnight and come back the next day, have the Dilapan taken out, and then proceed to amniotomy and oxytocin use. So it allows you to be able to do elective induction of labor policy, which is why it is an important factor. Although some units might see that more women will need a specific amniotomy and oxytocin use, I think in my view, the use of Dilapan is probably likely to be a more predictable way of actually managing your induction of labor policy. And I think that should be the last slide. So thank you very much, and we'll deal with any questions at the end. Thank you.
Lovely.
So Dr. Zaher is now going to speak about Dilapan and specifically about the inpatient induction of labor cost consequence model.
Thank you. So firstly, good afternoon, everybody, and it's lovely to see so many names in the group there, so that's excellent. So as Mike said, my name is Sue Zaher, and I'm a consultant obstetrician and the labour ward lead at the University Hospital of Wales in Cardiff. So following on from Prof. Gupta's talk about the SOLVE trial, I'm going to share with you the results of the cost economic analysis comparing the use of Dilapan versus Propess for inpatient induction of labour in the UK setting. Next slide, please. So this piece of work aimed to evaluate the cost, the staff time involved, and any direct ensuing clinical consequences of using Dilapan compared to Propess for cervical ripening during an inpatient induction of labour. So why is this study important? Why did we carry this study out? Well, as all of you here on the call today know, induction of labour is becoming an increasingly common procedure, with most maternity units now in the UK reporting approximately a doubling in their induction of labour rates over the last 10 years. So that increase, unfortunately, has not been associated with a corresponding increase in investment, either in infrastructure or staffing, and that's meant that NHS maternity units now face a real struggle to deliver effective services. So this, as we all know, results in significant patient delays with consequences in maternal satisfaction. There are numerous complaints and concerns now that arise specifically related to induction of labour, and obviously the very real potential impacts on patient safety. And that's not to mention the increased workload and pressures put on an already exhausted maternity workforce. The publication of the latest NICE guidance on induction of labour supports the routine use of Dilapan and specifically mentions or proposes a broader list of suitable indications for Dilapan compared to pharmacological agents. So this work looked to assess how the choice of your cervical ripening agent impacts costs and resources for women needing induction of labour. Next slide, please. Okay, so this slide looks a little busy and complex, but if you bear with me, I'll try and talk you through it. The induction of labour pathway was modelled using a population level Markov model, which transitions throughout the patient journey of induction, starting at the very beginning at the admission and assessment stage, working through to administration of the cervical ripening agent and right through to birth. Care pathways and the staff workload were modelled using data from the SOLVE trial, which we've just heard about earlier, and from UK clinical practice. All women entered at the admission and assessment stage, and at the top there you'll see a little box for prescription. For those women receiving Propess, a prescription is required. Those receiving Dilapan, they move straight through to that other time point, waiting time. All women progressing through the model received either Propess or Dilapan until they either had those agents removed or they fell out. There's then a further waiting time point which reflects real life situations, as Janesh referred to, where movement up to your labour ward is dependent on staffing and resource availability. After this point, progression then is to the initiation of labour, so that's either by amniotomy or going into spontaneous labour, with or without oxytocin augmentation. The final time points on the model are either your vaginal birth or birth via caesarean section. Now, obviously, at various intermediate states, women could move to the caesarean section time point. However, we haven't added that onto the slide, otherwise it would have been an even busier slide. Next slide, please, Mike. So, as we've mentioned previously, the model accounts for the 3 stages of an in-hospital labor-induced birth. So the first part is your admission and assessment, or your patient preparation. The second is the insertion of the actual cervical ripening agent. And the third is the induced labor or active labor until you have birth. So the next few slides, I'm going to be talking or focusing on the staff time savings or advantages of the 2 cervical ripening agents compared together. So the first staff time advantage here conferred is right at the onset. So there's a time saving of approximately 10 minutes of obstetrician time, and that's attributed to a saving with Dilapan, primarily due to the need of prescription by an obstetrician for Propess, which in real-time terms means that a midwife has to wait for an obstetrician to attend, review the patient, ensure there's no contraindication, make sure the patient's still happy to proceed, and then prescribe the Propess. Next slide, please. So the real staff time advantage identified by the model, and perhaps this is the greatest time saving offered by Dilapan, is the minimal requirement for fetal monitoring after insertion of Dilapan. So as Prof. Gupta mentioned in his talk, from the SOLVE trial, it was identified that there's a very limited risk of hyperstimulation, and also there's a reduced need for prescription-only opioid analgesia during cervical ripening with Dilapan. So the model predicted a time saving of approximately 140 minutes less staff time required for a woman that was receiving Dilapan for her cervical ripening than compared to a woman receiving Propess for cervical ripening. Your Propess administration requires repeated fetal monitoring, as we all know, every 6 hours after insertion. Your Dilapan can remain in situ without any additional monitoring for the ripening period. The added burden to a midwife, obviously, of managing and scheduling the monitoring of these women, analgesics, not only just of a single woman, but of several women, wasn't factored into this model. So this model is kind of modeled on a per patient basis, but obviously in real life, you've got more than one woman being induced, and a midwife's quite often juggling the care needs for these women. So perhaps if we manage to add this into the model, the cost saving or the time saving advantage for Dilapan would have been even greater. Next slide, please. So as we know from the data published by the SOLVE trial and other publications on Dilapan, there's no reported evidence of uterine hyperstimulation with Dilapan because of its mode of action, as we mentioned earlier. With Propess, there's a reported hyperstimulation rate of about 4.3%, with a predicted time of 2 hours of midwifery time taken up per hyperstimulation episode and half an hour of obstetrician time. So these events of hyperstimulation, they're not only staff intensive, but they cause interruptions to the induction process, both for that woman and for other women on the induction ward that are receiving their inductions. And not to mention, obviously, the possibility of transitioning or exiting the pathway and ending up with a cesarean section at various time points. Next slide, please. So again, from data extrapolated from the SOLVE study, we know that women who undergo the cervical ripening with Dilapan are less likely to require analgesics compared to Propess. Most commonly used analgesics are mild opioids, such as your cocodamol, your codidromol, and stronger opioids, such as pethidine, morphine, or diamorphine. All of these require staff time for prescription, administration, and monitoring. And this obviously results in interruptions in the ripening process. So the table below illustrates kind of the percentage requirements for the various analgesic options. And if you can see there on the first row, the mild opioids, over 43% of women require at least a mild opioid when using Propess for cervical ripening, compared to 21% with Dilapan. Next slide, please. So if we summarize our results of the study, the main findings are the predictions of the model of a reduction in birth-related staff burden when using Dilapan. The use of Dilapan for cervical ripening gives us a staff time saving advantage of 147 minutes less midwifery time for women and 11 minutes less obstetrician time per woman induced when compared to Propess. Now, in the context of increasing induction rates, due to obviously recommendations from national studies such as Saving Babies' Lives and the Gap and Grow initiatives, there's got to be a real importance placed on cervical ripening agents that will give us any efficiency, either in terms of cost, be that monetary or staff burden costs. Next slide. So this cost-consequence analysis, I mean, everything does always come back to money eventually, concluded that the adoption of using Dilapan for cervical ripening is likely to be cost neutral, which is important. It's got a negligible reduction of £6 in overall birth costs. So the total birth cost for a woman being induced with Propess is £3,531. And 3,525 for Dilapan. We split this further into the 3 stages of the model. Admission and preparation time is cheaper with Dilapan, and that's mainly due to the fact that Propess requires prescription. The insertion of cervical ripening agent stage is also cheaper with Dilapan due to the reduced monitoring requirements and as well as the reduced analgesic requirements. Where a Propess becomes a little bit cheaper, it's the cost of labour and birth, and this is as because of as Prof Gupta mentioned, the fact that more women go into spontaneous labour with Propess with less requirement for oxytocin augmentation. Next slide, please. I think this should be the last slide. So these are really just, I'll leave that up there for context. These are the references that we used to inform the costings for the model. Thank you all for listening, and yeah, I'll take any questions.
So there's been one question come in, Sue, which I think is best for you. It says, have the costs of oxytocin use and CTG when in labour been added in? Yes, they have, and I think that's why Propess comes out cheaper during that first stage of the modelling in terms of it makes up the cost. So we know that more women require syntocinon with Dilapan, and so yes, if you add the whole birth process right from the beginning, it's basically cost neutral. But the real advantage of Dilapan is in terms of the staff burden attributed to utilizing Propess, and there's certainly less staff burden and staff time when using Dilapan. And also, were there any differences in the duration of labour, and if any cost differences between those? No, I think that's as Janesh has mentioned in his study. The timings are pretty much the same, with similar rates of vaginal delivery rates. And Janesh, another question's come in relation to the SOLVE study. Were there any perforations or lost rods during this study?
Yes, it's always an important question to ask. If you want to stop sharing the screen now, Mike, it is an important question. No, there were no cervical injury or lost Dilapan rods. Sorry, there was one case of where there was a cervical injury that led to some bleeding, but it settled very quickly. But it's about the training of putting the rods in, similar to, you know, whenever you're trying to put anything through the cervix, you will get some resistance that occurs. And so it's really important that when the rods are put in, the first rod is actually then the marker for subsequent rods, because you can railroad the rods through. But it's a technique that needs to be learned. There's no doubt on that. And you know, a lot of our trial patients were actually all virtually done by research midwives. So once they got good at it, they were using a labour ward room where they were putting the women's legs more comfortably, like a lithotomy, in a room, getting the women to relax with Entonox and then fitting the rods in through the cervix. So I think it's important to just make sure you put them in carefully, but there were no cases of any lost intrauterine devices that were subsequently found. And that's consistent with other studies as well.
Is there anything on this question, Sue, you'd like to add at all?
Yeah, so I would agree. I mean, we've been using Dilapan since I think September 2020 in Cardiff now, and it's not a certainly not a research, wasn't part of a research trial for us. So we are lucky enough to have a core induction group of midwives, and key is absolutely the training and investing in the training for core staff, so that they become familiar. As Janesh has said, there's always a period of training and learning, and once you get over that, insertion becomes much easier. We have a dedicated bed. We invested in a bed, and I think that's the other important thing is the positioning of patient to allow correct insertion and easier insertion to avoid cervical injury. But we've not had any reported incidents of lost rods or anything like that. There has been the odd PV spotting afterwards, but more related to the number of attempts of insertion prior to asking for medical assistance.
Brilliant, thank you.
There's another question about the use of induction in specifically VBACs, and I think this is an important factor that's going to be a bigger issue as time goes on. We know that because there is less risk of hyperstimulation, less risk of uterine activity, we know from the VBAC guidelines that the risk of uterine rupture is associated with the use of prostaglandins. That's well established over many published papers. So the use of mechanical dilators will become an important issue, I think, for this specific group. We did not look at this group in great detail. We only had, I think, about 10% of women which were VBAC patients having Dilapan versus Propess. Women's Hospital in Birmingham, we use Propess for VBACs. I think we are likely to now change, in fact, we have now changed the policy to not use Propess, but we're going to use Dilapan. So I think that the success rate in the small group of women that were given Dilapan and Propess, the success rate was about 50%, and that's again consistent. So there's no difference in outcomes, but I think the safety issue, you'll need thousands of patients to identify this, but I think it's safe to say that it is safer to use Dilapan in those with VBAC. That would be my view.
Brilliant, thank you. We've had Tracy K in Royal Devon had quite a few questions in relation to some of the differences that they were seeing in their trust. Tracy, I think some of these questions might be easier answered by the support from Mike and one of our product specialist midwives, so that they can really see what's happening in your trust and how they might be able to support a little bit further. But
can I just ask the question though about the radio-opaque part of the string? So I'm really comfortable with Dilapan. We've been using it since lockdown, and we use it for our VBACs and our home births. So actually, you know, I'm really comfortable. I was just asking questions about the some of the reports. But when we did start using it at the beginning, we did have a lady who we had less counted out than going in, and it probably went down the toilet, but it caused a lot of anxiety right at the beginning of our use. And I did ask the team then why on earth the little bit of string isn't radio opaque, because the only way you can find these Dilapan rods, if they had gone anywhere else, was to do an MRI. They talked about using ultrasound, but ultrasound is only good at showing you that the cervix is dilating. So I think from a safety point of view, it would be good to put something in them that shows up on an X-ray, as we do so in swabs and other instruments and other things that we place inside somebody.
So Tracy, I think that's reasonable, but it's again, it's a manufacturing issue that they would have to take up. But from the numerous studies that we've been involved with, there's been no, even we use it for very complex abortion cases. We've not had a single case where we've had a concern of lost Dilapan. So I think it's just unfortunate that you've had that experience, but it is not something that we have found in very large numbers of cases, not only induction of labour, but also high risk abortion cases with advanced gestation as well.
One other question that's come in is the model suggests less epidural rate in Dilapan despite increased use of oxytocin. Can you explain that a little bit further, please?
So less use of epidural?
Yes.
I think that we didn't. I think CETA looked at the actual data regarding this. So CETA was the economics modeling, and perhaps she can answer this, but I'm not quite without looking into it, but I wasn't sure that there was a difference between the two.
I'm here as his CETA. I answered the question in the chat for anyone who wants the specifics, but what we did was to separate the epidural use between cervical ripening and labor phases. And during cervical ripening, epidural use was less with Dilapan-S, and the use with and during labor was, I think, maybe even a bit more. I could look it up, but we separated out. And so what you saw in the slides was during cervical ripening, because that made a time difference, and during labor was also modeled and is also in the costs. And I can look it up. I have it here somewhere. Rafa also is also here, and he's giving the details in the chat. So he's the one.
I wonder if the question refers to the table that I had in my presentation on the analgesic use. That table refers to analgesia that was used during the cervical ripening phase, not labor.
Exactly, yes.
So I'm wondering if that's what they're referring to in terms of.
That's the thing. It's the use was during cervical ripening that we put on the slides.
Yeah. So we know that obviously during cervical. Sorry, Seated. That during cervical ripening phase, the greatest use of analgesia is the mild opioid analgesia, followed then by stronger opioids. There's very little use of epidurals or Entonox, but that table refers specifically to cervical ripening.
Yeah, so I can answer this question now, looking at the tables that's in published data. The amount of epidural use was virtually, 1 or 2 patients for the cervical ripening process, but use of analgesia in epidural during labor was virtually the same between the two groups. About 50 to 55% of women were having epidurals, which is non-significant difference between the two. So whilst the labor process is taking place, there's no difference.
Thank you. And Professor Gupta, someone's asked what percentage of women required a second round of rods in this study?
Yes, so again, I would need to refer to my... So there was a group of women that needed second and third rounds, and this was particularly so if you didn't manage to get the internal os traversed through with the cervical rod. And we know that this occurs because your cervical ripening effect, we find this in abortion cases, your external os changes, but your internal os is what really needs to change as well through the mechanical and osmotic softening effect. And the numbers, whilst I'm trying to speak, is there were second and third series, but they were much smaller. I can come back to you if you have another question.
Perfect. No problem. This question, I know somebody has answered it in the chat, but Louise, if you don't mind just commenting, someone's asked, do you need CTG during Dilapan insertion?
No, you don't.
No, thanks, Professor Gupta. Dilapan is not an indicator for CTG.
Sue, is that how do you want to comment on how you do it sort of in your trust as well?
So, I mean, theoretically, you shouldn't need a CTG prior to inserting Dilapan. I think just because of good practice, at the moment we are doing a dose regimen CTG prior to, so that's the antenatal computerized antenatal CTGs prior to insertion. I think just really more because it was when we were introducing something new, it was to give confidence to staff and confidence to patients that baby was well prior to anything being inserted. But it's certainly after the kind of the post-insertion monitoring requirements are much less with Dilapan, and we've taken out any of those requirements.
Brilliant, thank you.
Okay, so I can go back to the number of series, and it would be easier if you can see this, if you can see my results table. Everyone see it?
Yeah.
Okay, so you can see series number 2, there were 150 women who needed the second series. Dilapan was in 59 patients and dinoprostone in 91 patients. And that was because of either the slow and failure to ripen, and it had fallen out as a reason for why it was used. And then series 3, there were only 21 patients overall, 9 in Dilapan-S and dinoprostone. So essentially what it shows is that the number of you do need to have a series, a second and third series, but in much smaller numbers. But we noted that really the main reason was because the internal os hadn't been breached, if you want to call it that, with the tip of the rod. So a training issue, I think, is very much so. Get that first rod through the internal os, and it's game over. It literally is game over. Even if you get one rod in our cases, it was 4 to 5 rods. Leave it in for 12 to 14 to 15 hours. The evidence suggests you will get cervical ripening, change in Bishop scores by at least 3 points, which means your cervix is going to be ripe. You can then get these women amniotomy and oxytocin, and you have a very elective method and not so much of an emergency rip-roaring effects of prostaglandins taking place.
Brilliant, thank you. I've just got a quick question, probably for you, Louise. I know we've sort of touched quite a lot about the internal os, but someone's made a point here that if the internal os might be tightly closed, if they've had a previous section or something like that, what would be then the preferred method of induction if you can't get anything through the internal os?
What you can do and what we recommend is to insert 2 dilators into the cervix for about 4 to 6 hours. And then what you can do, because of the changes in the cervical consistency, what you will find then is that the internal os should then be open. And then you can reassess, and then you can insert the dilators through the internal os. But like Professor Gupta has just explained, it is so important to insert those dilators through that internal os, because otherwise you will probably just either find them in the vagina or they will probably fall out. So it's really, really important to make sure that those handles are at the external os on insertion. But if the internal os is closed, that's what we do currently recommend.
Yes, you normally find that actually it's highly unusual that you can't get it through. The reason for that is because you have to stabilize your cervix. Like when you put a coil in a non-pregnant woman, you have to stabilize the cervix, and you can use a grasping instrument, could be a single tooth Valcellum or a sponge forceps, and usually either a plastic forceps or a metal forceps. Sponge forceps would be useful. You need to stabilize that cervix, and then with counter traction, whilst you're pulling on that anterior lip of the cervix, good view, get your Dilapan in through the internal os. You'll feel a small give as you get it through the internal os. It's a very satisfying feeling, and once you do get it in, you know that you're going to get a good effect, and subsequent ones you can then railroad through into the internal os in. And so it's remember, this trial was done in primarily nulliparous women. 80% of women were nulliparous. So it is successfully placed in the vast majority of cases.
And Louise, do you have anything to add on this point?
Yeah, what we don't do as midwives is we don't often recommend this so much anymore. So as midwives, we don't necessarily recommend using the sponge forceps to grasp the anterior lip. We don't necessarily do this so much anymore. So at the moment, we are just using the two dilators into the cervix and just seeing whether the internal os will open that way.
And there's one other question that's just come in. Do you advise removal immediately following SHROM? Louise or Sue, do you want to comment on what some other hospitals are doing?
Louise, do you want to just say what the recommendation is from company, and then I'll say what we do.
Everyone is different, to be honest. So every trust is different. So the manufacturers recommend that Dilapan can be used if there is SHROM, but for a maximum of 12 hours. However, every trust has a different recommendation. So it's really important that you check your trust guidelines, but a maximum of 12 hours. So it is really important to check your trust guidelines.
Yeah, so that's correct. So I just wanted you to kind of say what the party line was, as it were, first. But certainly we're one of those trusts where we don't use it in SHROMs, and we would remove it in SHROM, same as we would with Propess.
Do you have anything to add at all, Professor Gupta?
Yeah, so I think if you get ruptured membranes, you can leave it in. We know that the effects of, because it is a synthetic material, it is not an infective process, it does not increase your risks of infection. Like the old laminaria tents they resulted in toxic septicemia and so on because it was a natural product. We know that with Dilapan, it is a synthetic, completely sterile piece of kit. It goes in. If you get ruptured membranes, you can leave it in. You don't have to take it out. Just leave it in, maximum 12 hours. Let it work to do the cervical softening effect, and you'll find that then all you may do is need to use oxytocin thereafter. But remember, the whole principle of actually putting or starting the process of induction is heavily based on the cervical ripening effect, and the rest just follows very smoothly. So in terms of, can you use it for women who've undergone spontaneous ruptured membranes? The answer is yes, although we didn't have that in the trial because we excluded women with ruptured membranes with a cervix that wasn't ripe. But it is reasonable to use it in that context. But again, check with your local policy.
And quickly, one question for you, Louise. I know we've already spoken about sort of second and potentially third rounds, but if the first round is unsuccessful, can you use a second round?
You absolutely can use a second round of Dilapan. We would recommend, though, to offer the patients to mobilize before you immediately insert a second round of Dilapan, just to give patients a chance. But yes, you absolutely can.
Perfect. That's all the questions that have come in the chat so far. Mike, do you want to just share those last couple of slides? And if anyone has got any questions, just continue typing them in the chat and we can come back to any at the end if there are any more.
Yeah. So we've just got a couple of slides. Just basically summarizing what our two expert speakers have spoken to you about today. So in terms of the SOLVE summary, it was a trial that was open label, had superiority, and was a RCT in 4 English hospitals. As mentioned, there was 80% were primates in both groups. The Dilapan-S had a first round cervical ripening success rate of 10% higher than vaginal dinoprostone, and there were 0 failed Dilapan-S insertions. The delivery rate was fully comparable. There was a significantly reduced need for analgesia, and there were also fewer instances of uterine tachysystole, hyperstimulation with NR-FHR, and there were less adverse effects on the fetus. There were also lower pain scores during both the insertion and the ripening process. And subsequently, there were better outcomes for maternal satisfaction. So that's just a summary on SOLVE. In terms of the UK inpatient economic model, we found that the model was a cost consequence analysis based on the data from SOLVE in 3 maternity units. It used a Markov model and looked at the time horizon from admission for induction labour to birth. And what was found was that Dilapan-S was associated with a reduction in staff time, on average a reduction in time of 2.4 hours for midwives and 11 minutes for obstetricians when compared to dinoprostone. And we also found that there was the use of Dilapan-S is likely to be cost neutral when compared to vaginal dinoprostone as well. So the last point there was that the model predicts a reduction in birth-related staff burden, which should be able to free up staff capacity, especially during these periods of high demand. So the next slide, which you should be able to see, this is an example of a Dilapan-S induction pathway, and I'd just like to pass this over to Louise to maybe just talk through quickly.
Thanks, Mike. And good afternoon, everyone, and thank you for your time today. This is just an example. So this is basically just a guideline if anyone would like to follow it. And it's basically something that we can tailor to your needs, so to your trust needs. And our account managers can help you with your SOPs and business cases. So just to start with, as per the NICE guidelines, if your patient has a Bishop score of less than 6, your patients are eligible for Dilapan. And we do recommend a set of 4 to 5 dilators inserted and around 6 to 10 p.m. And the reason why we recommend around 6 to 10 p.m. is that is our optimum insertion time. If they're eligible, so outpatient is what we recommend. If they're eligible, they can go home. We know that that increases the natural oxytocin release. They're able to sleep. They're able to be with their families. They're comfortable. We've done numerous research to find that Dilapan is comfortable for patients to be inserted, and they don't necessarily feel them whilst they're inserted. So they're able to rest. They're able to sleep. And on removal, after they've been well rested, they come back into the unit, or if they're inpatient in the morning, they get removed between 6 a.m. and 12 noon. And during this time, after they've been removed, they can then be reviewed. And during this time, we know that a ward round is about 9 o'clock. So they can be reviewed after removal during ward round if needed, or mobilised whilst waiting for an ARM. Or in some cases, have a second round of Dilapan. Now, what I'm going to do is I'm going to pass you over to our Senior Account Manager, Charlotte, and she will go on to our next slide. Thank you very much.
Thank you. So I just wanted to introduce you to the rest of the team. Obviously, Mike and myself make up part of your key account team, joined by our colleague Lydia. Your key account team will help support you all the way through your sales cycle with Dilapan, so all the way from initial meeting and presentation, supporting you along the way with additional resources like SOPs, business cases, or whatever you might need to support your journey with Dilapan within your trust. You then have your product specialist midwives, Louise being one of them, joined by Shelley and Beth. And the product specialist midwives will help support you with your trial, any hands-on training, and then you will continue your journey with Dilapan with your product specialist midwives all the way through your journey as a customer, with continued support and training for whatever your trust may require. You can see all of our contact details on here, and if you have any additional questions or want any further support within your trust, please feel free to contact us. There's just been one final question that I think might be worth asking. Louise, which length of Dilapan rods were routinely used for cervical ripening, and is the cervix length measured prior to insertion, such as measuring using an ultrasound?
So the length of Dilapan is 4x55, which are used for induction of labour. The time that or cervical length is only really measured if we have patients that have had any cervical surgery before pregnancy. So if they're at risk of preterm labour, for example. But that's it as far as I'm aware, unless anybody else has got anything else to add.
Yeah, just to note that obviously for the other indications that Dilapan can be used for, such as termination of pregnancies and embryo transfers, there are other lengths that can be purchased, but there is a specific length for each indication. So just note that when you are ordering. But if you are ever confused, just get either yourself or your procurement team to get in touch with your local rep, and they can send you the purchasing information just to ensure that you are purchasing the correct rod. I think that is all of the questions in the chat, and right on time.
Well, thank you so much for attending today. As we mentioned earlier, these slides and the recording of this webinar will be available, and our details are on the screen. Don't hesitate to get in touch if you have any further questions. So thank you very much.